Good morning. I'm Dr. Leary, and I am currently in Norway House, Manitoba. We were unable to hook up the Skype, which I thought was quite fitting for a technology conference. So I'm doing the video so that I'm still able to do the presentation, sort of. So I hope that this gets through. I'm a primary care physician, and I'm from Norway House. I'm also First Nations, and I was asked to speak to the conference, and I guess my topic would be the frontline challenges of Northern medicine and how eHealth can help our patient improve patient care. This is what I know. This is what I do. I've worked in Thompson for 3 years as an emergency physician, and then also now I'm in Norway House practicing primary care. So before we talk about how eHealth can help the patients and how we deliver care, I think it's important to go over the basics. So the basics being that sometimes phone access isn't always there for our patients. Sometimes phone access isn't there for our physicians. Internet access isn't for everybody. We do have cell phones, we do have MTS up here, but the service isn't good, and you can't watch videos, you can't download information, it's very slow. So asking people to go home and access the internet to look up things in terms of diagnosis or how to manage, say, their diabetes or their high blood pressure, the things that everyone else has, those resources that they're able to access, we just don't have that here. So it's really difficult because how can our patients be health consumers if there's nothing to consume? So the internet access is a big barrier for our population here. The second thing I want to talk about is that EMR is not universal. So the electronic medical records that I think most clinics in Winnipeg would have, most clinics in the province have, we don't have. And we are in the process of getting electronic medical records. It could be another year, maybe two, before things are up and running properly. But we're 10 or 15 years behind everybody else. So that's a bit of a barrier for us. I like paper charts, but they have their difficulties. Looking through the information is difficult. Finding the exact piece of paper that you need is difficult. And then also keep in mind that everything is put in there physically. So a lab that comes back, a consult letter that comes back, it has to be physically be put into the chart by people, which can be, time intensive and also can lead to error. So in terms of, let's say a consult letter comes back and it gets dropped, or a lab gets dropped and things get lost, then that could mean a recall for a patient. And a recall means getting called to come in as a walk-in to see the physician when they have time to talk to you about the issue that you're being recalled for. And it's difficult. It's difficult to get a hold of patients, and when they do come in, because we're busy and we only have usually 4 physicians on the ground at the time because one's on call and one's post-call out of our 6, then it means that there can be some delays. So that could mean that you're sitting in the clinic from 9 a.m. till 3 waiting to see the physician, and that's a whole day. That's people's whole day. So losing a piece of paper from a physical paper chart, can be a big issue. So also, in terms of eChart, we do have access to eChart, but not in the computers that are in our offices. So if we need something from eChart, then we go to medical records or we ask the nurse manager to pull it up for us. Again, these things take time because usually that physically means walking down to medical records, asking them to pull it up, waiting for them to get it, bring it back to you for you to review it. And all of that time that you're not you're doing administrative work, you're not spending with your patient, you're not working on patient care. And physicians can do administrative work, but it's not the best use of our resources. Another issue with the paper charts and no electronic medical records is that it is all about time. So patients are seen, say, in the emergency room over the weekend. It could take 2 to 5 days for those notes from the emergency room to get into the chart. So if you see the patient for follow-up, you don't know why they were seen. They don't know why they were seen sometimes. They don't know what was given, how much the antibiotics that were given, all of that kind of stuff. So it just makes a lot more work for everybody. The system doesn't run nearly as smooth. The other thing that like eHealth could really help us with is having access to the DPIN. Now, the DPIN is a sort of prescribing database where it shows everybody in the province of Manitoba all the medications that you were prescribed from a physician, like that you got from a pharmacy in the last 6 months. So any doctor, any clinic, anywhere, any pharmacy in Manitoba. So we work really hard with the Northern Medical Unit and Norway House to try and decrease prescription drug abuse. So we have people on opioid contracts. We don't do these things lightly. And so it's really important for us to know what patients are getting in the city. You know, if some of these patients are traveling to the city, we need to know that if they're getting prescriptions from other places. We need to know what other doctors are doing. We need to be able to have that, that conversation. So having access to the DPIN is really important. And it also means a lot less time of me spent on the phone talking to a pharmacist and asking, what is the patient on? These 10-minute phone calls, right? You're trying to, get all this information when you could easily have a printout and have it there right in front of you. So another issue is our x-ray system. And so because Norway House, Hodgson, and the nursing stations are federally run, the x-ray system is by the feds. So we use a Synapse system, whereas the province uses PACS. Now, everywhere else in the province has PACS. They can all talk to each other. You can get an x-ray in Flin Flon or Thompson or Pine Falls, and the ortho specialist can see it in Winnipeg. They have access, province-wide to these images, MRIs, CTs, ultrasounds, all of it. It's all there. So it makes it really easy when somebody comes in and says, oh, I had this done. I don't, here's what I think it said. You can just look it up. We can't. And that also means that there are some limitations in terms of providing care for patients. Because when we have somebody who's had a trauma, or we have somebody who's, had a broken bone of some sort of dislocation, the orthopedic surgeon wants to see the film. And the only way for us to get the film to him is to physically send a disc or the patient themselves. And if we're talking about, funds and we're talking about trying to decrease patient transfers, then that's not a good system. So, right now we're working on a system for non-emergent ortho consults to be seen electronically. But these are things that are already happening all across the province. So, this is a big barrier for us, a big barrier to care. So, just one other thing to think about. We find ways to get around these things. We find ways to, manage our limitations and to work with our system. We love the work that we do. But one of the things that I've noticed is that I wish was different was the lack of communication between specialists and the primary care physicians. Because when a patient has an appointment in Winnipeg or Thompson, we have to wait for that note to be dictated. And then the note has to be transcribed and then put into their charts and then faxed to our medical records or our front office. And then somebody has to see it, or medical records has to put it into the chart. That's a lot of time. And so we usually end up seeing the patients in clinic before we even get the consult letter back. So a lot of times that results in a patient encounter where I'm asking, what did the specialist say? And then they say, I don't know. So you spend a lot of time just trying to figure out what were the recommendations, what's going on, where are we supposed to go from here, and also trying to help the patient understand what their disease process is. We as physicians are sometimes not the best communicators. Perhaps we don't always take the time to explain things to patients as we should. And even if we do take the time, they perhaps don't understand us. And if we can't explain things in a way that people understand, then there remains a gap in the communication. I think we have to remember that non-medical people don't have a lot of medical knowledge. The terminology is different, and as doctors, we forget that. We forget that not everybody talks like us. So that can be difficult. So I think having, through eHealth, having a more direct doctor-to-doctor communication system would be really beneficial. It'll be a lot easier to set that up than teaching doctors how to teach people. Teaching doctors, how to talk to people properly. That'll take some time. So a few other things, just quickly. I know I'm running out of time. Emergency telehealth. Thompson's doing it for nursing stations, but in terms of nursing stations and our hospitals, being able to access trauma surgeons, when we have horrible things coming in the door, then that would be really helpful. And physician support when we don't have transport, when we're weathered in or perimeter's not flying or there's no medevacs because they're timed out. Having that support there when we can't get patients out that need to go out would be really, really helpful. And then also possibly, through telehealth or through eHealth, having psychiatric assessments. So instead of having to send every patient who we have deemed medically necessary needs a psychiatric assessment, instead of having to send them to the psychiatrist, being able to have, facilitate that conversation without sending them out, because that does mean that we're using resources, because every person who is formed has to go out with our CMP escort. That's a lot of time, it's a lot of people that, go into transferring patients. So those are sort of the big points I want to talk about in terms of our challenges. Now, I'm not saying I have solutions for all these challenges, but this is sort of what we face on the ground day to day. But perhaps the biggest take-home message that I would like everyone to hear is that we need to start providing care to the people where they are. It's unacceptable that people only get complete care in large urban centers. Everyone deserves access to complete good health care, no matter where they're located. That shouldn't have to mean relocating from your home, leaving your family, leaving your support systems, leaving everything that's familiar to you. Living in an Indigenous community or living in a remote or northern community should not be a risk factor to your health. I think that the care needs to come to the people who need it most. So I think that, these conferences for eHealth and exploring the technology are great ways to do that. So thank you very much for asking me to speak. I'm sorry that the Skype didn't work. I wish I could answer your questions. If you have any questions, you can send me a letter. Okay, have a good day. Bye-bye.